Good morning, my name's Fiona Adamson. I'm the Chief Exec of Hartlepool and Stockton Health GP Federation and the proud chair of the almost brand new Primary Care Federation Network. Thank you for attending our session today, even if you didn't get a day trip to London this year. We have rather a dry title, but our board members will be bringing that to life for you over the next 50 minutes or so, with some real life examples of what federations are doing nationally. There'll be a chance for some question and answer, and also we are really hopeful that by the end of the session, you will be dashing off to find your local GP federation to start or continue a conversation even before you put the kettle back on. So before I start, I'm often asked, what is a GP federation? And the answer is there is no single size. However, we have lots of commonality. So we are of general practice, we are of the NHS. We are often membership organisations, and you'll tend to find us in an area where something needs to be done at scale. And that was often 7-day access to general practice when we first formed. So you'll find us doing that. You'll find us supporting our practices and our PCN members to help them deliver the care they want to. And you'll also find us at system conversations. So really building on those relationships that we all strengthened during the pandemic. So why the Primary Care Federation Network? Well, there are around 200 federations operating nationally, but actually we aren't represented in national policy conversations or strategic discussions. So that's the first thing. The second thing is we don't know each other, of course. So this is a great opportunity to connect and to create a virtual team, to learn and improve together. And I've learned loads already. And the third thing really is to support. And that might look like where there is a gap in a local system, we could help a network of networks or a federation to form. So I'm not going to read our vision to you. I'm really hopeful that by the end of the session, you'll want to click on the website and find out a bit more. But I did want to share our values because they are really important to us. The first one is that we're local, as I mentioned. We formed around a place. We're also of the NHS, delivering NHS services. We're great believers in integration, so using those relationships to work better together. And then finally, and really importantly, we have a social purpose. So we exist so that the health of our local population can be better. So I hope that's whetted your appetite. However, don't just take my word for it. We've asked lots of people that we work with up and down the land to tell us what they think about their local GP federation. Thank you.
We have struck up a really good relationship since the inception of the GP Federation, specifically more formally around an integrated urgent care centre and an alliance agreement which we pulled together to enable us to have a much better and more robust working relationship. And there has been some huge successes in the integrated urgent care centre which brought together multiple diverse contracts around out of hours GP care, around minor injuries units, around urgent care centres, and brought those together in Stockton to enable us to deliver a much more comprehensive service for our patients and our communities.
Our federation started as a conversation at the LMC, and therefore the organisations have always been fairly closely aligned. Over the last 12 months, with the COVID pandemic, we have seen the development of our GP leadership team. This consists of our clinical directors, the federation and the LMC. We meet weekly and we produce a single voice for general practice. We can invite partners, we can develop consensus, and we can respond to system demands. We have a small LMC and a large, well-developed federation. Other parts of the country will have different relationships. However, I think the real strength is coming together as team general practice. If we can produce a single voice to the system, the system will come to us and we can have far greater influence within the development of integrated care systems.
The GP Federation is a really important partner for us because it supports primary care's clinical connectivity with local communities, providing valuable infrastructure for primary care networks, strengthening their understanding of and place within the wider system. And for us, that's primarily through the Integrated Care Partnership, for example. Our GP-fed colleagues are integral to the acknowledgement, the continued development and mobilisation of the local voluntary and community and social enterprise sector in Bolton as they champion the benefit of local non-clinical wellbeing provision. The GP Federation values the community sector by investing in the commissioning of 4 sector leads, social prescribing, place-based peer navigators, and small grants that are invested directly into the heart of communities. And for us, the partnership is really, really invaluable.
Our GP Federation in Milton Keynes employs about 70% of all our additional roles across all the PCNs in Milton Keynes, and they provide supervision, they provide training, networking, support for the staff. They also provide the extended access for all practices and PCNs, so they have been really an amazing partner to work with.
Morning, I'm Andy Hilton. I'm a GP in Sheffield and Chief Exec of Primary Care Sheffield, and I'm delighted to be the Vice Chair of the Federation Network. Where federations are already well established, we can see that they add value and resilience to primary care and to the wider system. Providing infrastructure that wraps around practices and PCNs, they can reduce duplication, improve consistency, and harness the economies of scale so that primary care maximises its efficiency. They can provide whole population-based health solutions, coordinate services at a much greater scale, for example, integrated primary care access 24/7, while sharing innovation and best practice. As system leaders, federations can influence the transformation agenda on behalf of primary care as providers. The priorities for the network over the coming year, including that ongoing leadership, particularly as ICSs develop and we see CCGs absorbed into systems, will continue to provide that infrastructure, that wraparound support and that governance that will allow primary care networks to continue to develop and practices to flourish. Access is key to our agenda, developing extended access that it integrates with wider urgent care services and 24/7 access to primary care. Enhanced primary care across services such as planned care and the planned care recovery also form part of our priorities. Throughout the pandemic, we've delivered a range of solutions that have supported the COVID response and will continue to do so as the pandemic decreases, and will also support the recovery. The ongoing presentations are 3 case studies from federations across the country. First of all, Catherine Saunders, Kate Spenceley and Ruth Rankin will talk about how federations have been supporting practices and PCNs.
Thank you, Andy, for that really helpful explanation of the priorities of the network and the strength that federations can bring to the health and care system. My name is Ruth Rankin. I'm Director of Primary Care at the NHS Confederation, and I'm delighted to lead us into some of the real practical aspects of how federations are supporting the health and care system today and bringing to life what Fiona and Andy have talked about this morning. So I'd like to introduce my 2 guests, Katie and Catherine, and would you like to introduce yourselves, ladies?
Shall I go first? Yeah, thanks, Ruth. So I'm Catherine Saunders. I'm Chief Exec of ABC GP Federation, and we work with our 44 member practices in East Surrey and North West Sussex.
Thank you, Catherine. I'm Katie Spenceley. I'm a GP in Mid Sussex, and I'm a clinical director, one of 2 of us actually. We share the role for Haywards Heath Villages PCN.
Great, thank you. So one of the questions I'd like to start with is, how did you come together into a relationship? So obviously federations have been around for quite a while and PCNs are barely 2 years old. So just, was there a historical relationship? Or Katie, how did you come to realise that you needed support from the federation?
Yeah, thank you, Ruth. I think that realisation came very early on when we saw the spec of the DES as it came out. So as a practice, we are a member of the Federation already, and the PCN I'm in is 3 practices. We were all members of the Federation, and it was quite obvious from an early stage that it was good to work collaboratively across other PCNs, and just generally it all came about at the same time, didn't it, Catherine, that you put out a proposal of how federations could help us. I think initially it was a very basic offer talking about back office functions and a bit of finance help, and it has grown hugely in that time. And Katie, the other co-clinical director with me, we both say on a regular basis we could not have done this without our federation. As GPs, we're not trained in any side of management or HR or anything like that, and so we regularly knock on our federation's door to say, help, we really don't know what we're doing here. And it's just been invaluable. I think even pre-pandemic we could say that, but certainly post, well, not even post-pandemic, during the pandemic, we have really valued our federation and the support from other PCNs within that federation and other clinical directors as we work together to try and work out what this looks like for us.
So Catherine, how did you, or what was the opportunity that you saw then when PCNs were being set up? You know, given you had those relationships in place, what more did you feel that the Federation could do?
So I happened to join ABC as Chief Operating Officer to begin with at the same time that the PCN DES landed, and I think to begin with it was sort of slightly tricky for federations. It didn't, nothing really mentioned federations in what was coming out from NHS England, but to me, just reading it anew, and my background wasn't in primary care, it seemed like we were asking an enormous amount of general practice, really working in ways that they hadn't particularly done before, and that they were going to need a lot of support to do this. So it felt like a real no-brainer that my federation that I just joined, that had management capacity, that had finance support, that had some HR knowledge, that, you know, we'd cut our teeth on providing improved access as a federation, and now we could make use of the infrastructure that we were starting to build. So from there we said, okay, well, what's the basics we can do? And as Katie said to begin with, it was pretty basic, but we've grown together and the relationships are built together. As you know, PCNs have now done more than I think maybe they were expected to do right at the beginning with the pandemic. No one could have predicted how that would affect PCNs, but I think in a lot of cases it's actually been really positive for practices working together, and we've been there to enable that. So a lot of it is just about being responsive and looking and listening to see what's needed at the time.
And obviously one of the big opportunities is around the new workforce roles coming into PCNs. But that also provides challenges as well, because, you know, there's potentially 15 new roles that a PCN can employ, and, you know, there's quite a lot of work involved for PCNs on top of everything else they're doing. So was that a specific area of focus then for you, Catherine, in terms of the offer from the Federation?
Absolutely. So I think the basics that we provided at the beginning were to be a nominated payee and a nominated employer, which takes away some of the liability. So the sort of earliest questions from practices about what does this mean in terms of my liability if I get involved, we could kind of just take that headache away and carry a bit of that risk. So we started with employing the pharmacists, and where there wasn't a sort of a social prescribing service already established that PCNs could tap into, employing social prescribers. But you know, we talked early on about integration as part of our values. So we're not about saying don't talk to anybody else, we'll employ all of these roles for you. We're absolutely about saying it might be making, you know, it'll make more sense to work with your community trust around this physio role. How do we link with the ambulance provider now around the paramedic practitioners? So we're trying to really pull all of those different services in together. And often there's real advantages because we can have one conversation with a big provider that feeds down to the 12 PCNs that we're supporting, rather than each of them having to have an individual conversation. We talk in a minute about how we help PCNs develop their strategy, but I don't think any of our PCNs have exactly the same needs in terms of their population or where their practices are at. So we try and fit what's going to be the right development of your ARS roles to work with your PCN. And as we move on, we're more and more trying to get into developing teams that work across the practices in a PCN. But the support to those individuals, certainly at the beginning in the early days where you may be a lone pharmacist working across 3-4 practices, or a social prescriber coming in when the practices have never worked with a social prescriber before, we've really focus very hard on supporting those individuals as much as possible, and on supporting the practices to get the most out of them. So talking to them about how other practices in parts of the country might be using the role, making sure that locally the roles are joined into individual networks, so they've got that support and a bit of supervision as well. And we're really proud that because of that, we've got a good retention rate. It's still not always easy to recruit, but when we get these people in, they tend to stick around, and they tend to tell their friends as well. So we think we're doing okay there.
And Katie, can I ask you, were you worried at all about losing ownership of the staff because they're not directly employed by the PCN?
For us, I don't think that's ever been a concern. I think it's been the opposite, really, actually having the expertise to tap into. So we've sat down as a PCN board, we've looked at our strategy, we've looked at where the gaps are and worked out where we would like to go with the R's roles. Because as you say, there's a rich picking list, but we've only got a certain pot of money. So we then use the expertise of the Federation to help us from recruitment all the way through to now doing the annual appraisals, because again, it's not an area that we've been trained in as medics. So having somebody help us to facilitate and support those R's roles has just been excellent. And we have a network development manager through the Federation. We have Lena. I think everybody needs a Lena in their life. She's absolutely brilliant. And she will prompt me to say, right, come on, senior pharmacist appraisal is due. Let's put a date in the diary. I'll admit, I wouldn't have time or the headspace to do that as a busy clinician. So I think having the Federation to help us and assist with that has just been brilliant.
That sounds great. And you talked about the strategy, and I think there is a risk with everything that PCNs have got to do, and increasingly more and more is being asked of PCNs. The risk is that they just end up focusing on the to-do list and the day job, and given increasing demand at the moment, how do you create the space to think about where the PCN is going, really focusing on the fact that PCNs are not just about general practice, it is about that, that wider sort of integrator across primary care with community, optometry, dentistry, working with other partners in the system. So, how do you separate the sort of the day job from and free up your time to think about strategy and what support you need as an organization?
I think that's a really good question. I think we're still learning how to do that well, but I think what's been helpful for us, our Federation have led strategy sessions, whereas a PCN board, we've had protected time out to sit down and look at all sorts of tools that we've used. We've looked at the Rumsfeld, the known unknowns, the unknown unknowns, and helped us to develop where we want to be heading, looking at our area, looking at our population health management, again, a tool that the Federation have helped us with to sort of look at where the gaps are. I think we're still learning and we're still developing, and I think that's probably all been on pause for the past 6 months, and I look forward to going back into that and growing our relationships. So I think the pandemic has helped us grow our local relationships with other providers. So we're working with our Mid-Sussex District Council a lot more to provide the vaccine service. And I look forward to growing that based on what we've done so far. So that will be helpful.
And Catherine, what benefits do you see from your support to PCNs, particularly around the sort of leadership development and organisational development? How do you think that helps them?
I think it's essential, to be honest. And I think, as Katie said, this landed with a lot of expectation, but really also an expectation that resource was sourced locally, which is a great way of doing it. And I don't think it should be mandated, but I think often PCNs shy away from spending a lot of money on an external consultancy to come in and support them, and just can't really create the time and headspace maybe to kind of attend a separate national program. So what we've tried to do with our PCNs is keep a fairly low-key approach, but to do these strategy sessions, and I do really enjoy them, to talk about what's your shared purpose as a group of practices. So not just what have you got to do to deliver the DES, but what do you want to do? What would really inspire you to try and work together? And that can be anything from keeping our heads above water with recruitment to we really want to focus on children and young people's mental health in our area, because we think that's our biggest pressure. And once you start to get something that sort of really inspires people to work together, it helps to build those links. And then I think going on from that, the expectation therefore on the clinical directors, but also on the GP and the practice manager leaders for each of their PCN to start working as a network when maybe they haven't worked like that before, and to start to sort of pull in other organisations and to be talking at maybe a higher level than they have before. That's a lot to ask as well. So we've recognised that we need to do some leadership development. So we have a coaching programme for CDs and for practice managers, which is particularly geared to what are the competencies you might need to work as part of a network, and how do you start to develop those influencing skills. We've done masterclasses around particular topics. Just recently did one on service development. How do you kind of get into a culture of continuous improvement within your PCN? Also things on communications. How do you get your messaging across the PCN to your staff, to your patients? So kind of going where we identify a need and trying to put in a local solution there. And I'd really emphasise that bit, going back to what Fiona said on our values. We are local. We want to provide this right for our area. And we know that there's other federations around the country that are doing the same for theirs. And actually one of the things that is most helpful is I'm not coming into a group of practices as an external consultant with no knowledge. I will be in the meetings with the hospital chief exec, with the ICS execs, so I know what their local context is and can help them work out their strategy in that context.
Thank you very much. So that leads us into the next session, which was a nice segue in, because actually we're going to look at the role of federations in supporting elective recovery. And I'd like to hand over to Julia Griffith.
Good morning. My name is Julia Griffith. I'm the business director of BEMS, which is a GP federation in Bath and North East Somerset. We were formed in 2004 as a not-for-profit community benefit society. We were a GP out of hours cooperative. We now provide services, DVT, fracture clinic, vasectomy, urgent treatment centre, a suite of improving access services, hot hubs, evening and weekend primary care, home visiting, and the COVID-19 vaccinations. And we also run a referral support service. We provide training and education for primary care. We also lead service redesign in acute care and long-term conditions. We also employ staff for primary care networks like pharmacists and physiotherapists. We act as an honest broker between practices within the primary care network and between the primary care networks. And we're also the voice of primary care in the system. I'd just like to introduce Chris.
Hi there, I'm Chris Dyer. I'm consultant geriatrician and associate medical director at RUH for GP Liaison. And locally, we already had good working relationships with BEMS GP Federation and with primary care. And my role really was to build on that. And as a result of COVID, our local professional leadership network met fortnightly virtually, which greatly strengthened our dialogue and our actions.
Chris, why was the outpatient redesign group formed?
Well, our local network agreed that we needed to take the opportunities afforded by COVID, if you like, to embed the COVID changes, particularly in outpatients. So that would include advice and guidance, triage, technology, and other opportunities which are outlined in the NHS plan. We wanted to take a whole pathway approach, working with providers and referrers, and also to work closely with individual specialties so that we could effect real changes to our place.
Why was BEMS, as the federation, asked to chair, and what is the added value?
Well, having worked with BEMS for many years, you are regarded by us and other providers, I think, as trustworthy, as honest brokers, as you put it, by all involved parties, both in primary care and providers, including ourselves at the RUH in Bath. You're able to gain good understanding of the primary and the secondary care view. You've got a broad knowledge of what the primary care pressures are like, and you've got support from your constituency. You've also, I think, got a clear understanding of commissioning and pathway redesign. And so we identified 6 specialties between us to get our teeth into, which were large specialties, which were under pressure, and where there was also opportunity to engage with the clinical leads.
Thank you. Why do you think a GP federation and an acute trust working together is a more productive way of working?
Well, it really was, because it wasn't constrained by current processes such as finance. It was clinically led, and we all knew that there wasn't going to be a quick fix to outpatient redesign, but this is a sustained program of work. And both the GP Federation and the RUH are here to stay in the local community. And so this is about two providers working together to sort problems out. And we had a lot of senior support in the acute trust, for example, Deputy Director of Operations, the outpatients lead, and also myself. And it also meant that our local RUH outpatient group could focus on other themes such as consultant triage, on virtual consultations, on patient-initiated follow-up, and importantly, of course, a safe environment. I wanted to ask you, Julia, what do you think are the themes that have emerged in this interface between primary care and these 6 specialties?
Yes, thank you, Chris. Advice and guidance to GPs. We're trying to move away from an old-fashioned model of patients needing to go to the acute trust for their advice. Availability of diagnostics in the community has been a theme. Training and education for GPs and nurses. Referral guidelines and templates. We're very keen that referrals aren't rejected. And then the roles of GPs with extended role. And we're now going to talk a little bit about dermatology as an example of what we've been speaking about.
Yeah, well, there certainly was a problem with lack of dermatology consultants and being unable to recruit, which meant that routine waiting times had risen to 12 months and consultants really only able to deal with 2-week waits. And I want to ask you first, how do you think that hosting the training hub helped with dermatology?
Yes, so we were asked to host the training hub by NH Health Education England, and we've worked with yourselves to agree GP accreditation, training, and ongoing supervision, because we realised we needed to grow our own GPs with extended role as well as using existing ones, and we carried out a skills assessment of local GPs. And this resulted in monthly joint clinics with RUH consultants, which constantly increase the skill level of our GPs. And we've just started isotretinoin monitoring as an example. We're also, as a federation, able to source Health Education England GP fellowship funding, and we funded 2 GPs to take part in a Cardiff diploma in dermatology. That also helps with recruitment and retention in primary care. And then our GP, our RUH colleagues and dermatology nurses then also ran training sessions. So we had a forum, a primary care forum, which was part hosted by the Federation. Again, we go where primary care is, where they already meet.
Yeah, that's great, Julia, thanks. And again, with dermatology in mind, how has it helped by the fact that you provide the local referral support service?
So again, we were asked by our commissioners to host the local referral support service. It's trusted by local GPs to not be referral management. At the request of local GPs, we were asked to set up a dermatology triage service because it was so complex of all the different pathways for dermatology. So they now are able to send them all to the same place, and then our GP with extended scope navigates them to the correct provider. And then very importantly, we have live data on waiting times, activity. We know where there are blocks in the system from a patient and a GP perspective.
Thanks, Julia. And so what do you think are the benefits for the system in terms of this type of service provision?
So it utilises new technology, for example, teledermatology. The community dermatology service is provided in 3 GP practices. So we're utilising minor surgery suites that GPs already have. It helps with primary care staff to increase their skill set. And obviously it's closer to where the patient lives, being in primary care. We were able to set the community dermatology service up in 8 weeks. We're very agile. We've got an experienced team of managers. We're used to mobilising services fast. The waiting times are shorter. They're now 8 weeks. So we're really pleased with that. We provide 2,600 appointments a year. And our first to follow-up ratio is very low. It's 1 to 1.5. So we manage to manage people. Our patient feedback for this service, just some examples. First-class service, doctor very informative and caring. for the venue is very convenient, easily accessible for me, better than travelling all the way to the local hospital. Sorry, Chris. Staff feedback. BEMS is a supportive and flexible employer. It's clear that BEMS provides services that focus on patient care. And then we also did some audits, and we looked at infection rates, and there were none.
Thanks, Julia. I mean, the results are very impressive, and I think from a secondary care perspective, it's not something we would have been able to achieve on our own. And so in conclusion, really, from my perspective, is that it really has been extremely rewarding to work with a GP federation like BEMS, who are fully committed, nimble, and we know and trust the great management and leadership skills that also listens to and is in partnership with primary care, while also being an agile provider itself.
Thank you, Chris. And my concluding comments, I'd like to highlight the following. We're two providers with a track record of working together who are here to stay. Our outcomes, I believe, are of high quality. And there was real energy and enthusiasm from the providers' clinical teams. And it's one of those groups of meetings that actually participants genuinely give their apologies for, because it's really energized everybody. Well, thank you very much for your time and listening to our talk. I'd just like to say that Michael Smith, the Chief Officer of Bolton GP Federation and the Primary Care Federation Network member, will now be talking to you about federations delivering urgent care services. Thank you.
Okay, thank you, Julia. My name is Michael Smith, and I'm the Chief Officer for Bolton GP Federation and a member of the Primary Care Federation Network Board. And today I am going to talk to you about what federations already do or could do for you in relation to urgent care. And our perspective is a fairly specific one, in that Greater Manchester has had a fairly joined up approach to the delivery of extended access, as most of you will probably know it, over the last 4 or 5 years. And this is because one of the first things that the devolution team, as it was called at the time, is now morphing into the ICS. They wanted to make sure or try and promote equal extended access across each of the 10 boroughs in Greater Manchester. And you'll see from the map there that as well as the City of Manchester, there's a number of more outlying towns and boroughs that are all, for us luckily, coterminous with local authorities. So some fairly tight geographic identities in there. I also want to touch on, because I'm sure a number of you will be interested in, how federations have worked with emergency care and emergency departments. Because one of the things that Greater Manchester particularly has focused in the last 12 months, as I'm sure many areas have, is how do you try and mitigate pressure on emergency departments in the middle of COVID and social distancing and everything that goes with that. So today I'm going to talk to you specifically about 2 examples from Greater Manchester. And the reason I've chosen 2 is because every area is different, every emergency department is different, every population is different, and lots of different areas are in different stages of development or ambition or capacity. So I'm going to talk about what's happening in Salford with our colleagues at Salford Primary Care Together, and then a little bit about what we do in Bolton and where we've come from there. So the somewhat modestly titled Epic 24, as is delivered in Salford, is pretty much an all singing, all dancing, integrated front end for as much urgent emergency type care as you could imagine. So what they built here was a single digital front end that takes, as you can see on there, referrals from any number of referral routes. And the thinking here was to, as I'm sure much of you are considering, is what is urgent care is often defined by the patient differently to what is seen or perceived by ourselves in the NHS. And what they tried to do was trying to link up all the entry routes into and out of urgent primary care. And I'll come back a little bit later to the difference between how primary care potentially will deal things compared to emergency and out of hours. But by putting together a single hub, what Salford have done, as you'll see in the slide, is built something that I think federations are ideally placed to deliver. If you have and collect a kind of primary care central resource of knowledge and experience and combine that with a really robust digital solution, you can provide something which will coordinate all the demands for urgent care, so same day urgent care from practices. And again, that's one of the things I think we're all thinking about into the future, you know, with a number of different routes into primary care and the development of e-consultations. A number of us are starting to think about how do we manage that on a PCM basis or on a place basis. What Salford shows you here is that you can place a primary care, and it's very much a primary care approach to managing that on the day demand, and use it as the central point through which patients can be directed, signposted, referred directly to the service they need following primary care assessment. So they can come in via 111, or they can come in via A&E streaming, or via community staff in, in the community, or even, recently stood up services such as the pulse ox at home, and then be brought into what is a fairly familiar setting in terms of centralized triage, but then basing that on the GP record, not hand that off to somebody else, but book the patient into somewhere that will deal with the presenting complaint. And then beyond that, as well as all the NHS services, given the distinct nature of federations, is the link not only into mental health and other community services, but the voluntary sector and into social care. So you've got a really, really good full fat service there that ties everything together. Not everybody is that advanced, is that far advanced, for lots of different reasons. Salford have done a really good job with urgent care over the last 10 years or so. So I wanted to talk you through what's happening in Bolton and a slightly different approach and a different evolution. So what's happened in Bolton over the last 4 years is that we built a service that is very much intended to be an extension of regular primary care. So whilst it's still open every day, it's open Saturdays and Sundays, it's open Christmas Day and New Year's Day, it's very much designed as being a GP, if not your GP, but that GP and that service will be a Bolton service. It does same day care in terms of relieving pressure on practice, but very particularly it's built to manage long-term conditions, if that's useful. It's built to deliver services such as screening services, so to provide extended access, not just for that kind of on-the-day GP consultation, but the sort of broader range of what primary care is, because we all know it's much more seeing a GP. We also made sure, as I'm sure most of you have, a local quality contract of some sort, that people, that our staff and our services can ensure that they deliver elements of that for and on behalf of practice, so that it's not a service that sees somebody and pass it back to practice for work. As primary care moves and changes, again, many federations work with their PCNs to employ staff, the RS staff in particular. Again, we've expanded the roles within that, so that, again, patients who want to access in the evenings at weekends can access the same sorts of services as those during the day. So the MSK first contact practitioners, or be that mental health workers, pharmacists, link workers, to make sure that the service we offer is one that looks like what the sort of offer you get during the day. We've been really keen to make sure that while we develop this service, it works and it makes sense to the development of what's happening in neighbourhoods, to provide a service that can deliver the sorts of things that primary care delivers. So it is screening, it is long-term condition reviews. What we did last year, and this is kind of a sort of halfway between the two, is step up a streaming service to support A&E. And this is a very live issue for a number of us at the moment. And what we found there was, again, that replicating a primary care specific response to that allowed us to pretty much manage patients within a primary care setting on site in A&E. So again, it's about giving a primary care consultation with all the record and the information and the connections of a federation which is embedded in place, that can just offer by its nature a little bit more than maybe out of hours would. And again, they are two different things, but you can flex one to reflect the other. What I want to talk about next is where do we go next? If you are starting to think about what your federation can deliver for you. Where might you want to go? What are we thinking about? What are our colleagues up and down the country thinking about? From an urgent care point of view, another dreadful acronym, the local clinical assessment service, so that kind of digital or phone front end to emergency care. You know, how do we get a consistency of offer across Greater Manchester? You know, who's delivering it, how's it delivered, who's it connected to? There's some really interesting questions that we're all considering about the future extended access versus out of hours. Are they the same? Are they different? How should they work together? How could they work together? How does that make sense? And just exploring the opportunities in there. I touched briefly earlier about the growth of e-consultations. You all have seen the news in recent weeks about practices adjusting at different scales and at different rates to what happens without patients having different experiences of, if I email my GP in the middle of the night, should I expect a response the day after? How does it work? How does it best work? So again, is there some options based on what we know about from will work for urgent care? Is there some kind of similar offer for primary care? So do we all start to think about how we develop overflow? That's a dreadful phrase, overflow for e-consultations, ask my GP and the like. Again, I'm sure most of you have seen the recent developments in relation to community diagnostic hubs, and there's some obvious overlap for us in terms of, if you're going to develop diagnostic capacity in the community, it ought to be diagnostic capacity that works for primary care as well as secondary care. An example of that would be quality assured spirometry. We know there's a real mixture of interest and capability and skills right across primary care. So we're doing some work at the moment with the local hospitals, as are a number of our compatriots across Greater Manchester, to understand what the opportunity is there. Two final thoughts then. In terms of how the world looks in future, the integrated, joined up, working, whatever you might want to call it, so there is a distinct future. It feels like it's coming in terms of how PCNs and neighbourhoods work together. They do sometimes occupy the same space. There's lots of opportunities, I think, there for federations and the staff that they employ directly, or the connections they have, to be an integral part of how clinical services are shaped at a neighbourhood level. And that kind of connects to, how would you translate the sort of direction signposting function that is currently there for emergency care into that kind of MDT based approach to how you manage capacity and pathways at a local neighbourhood level. Lots and lots of questions there, lots of things to think about. I'll throw an enormous amount at you in a very short space of time. I'm sure many of you got some questions, and I'm sure the panel that's coming up next will be more than happy to answer them. Thank you all very much.
Well, thank you very much indeed. What a fantastic series of presentations. My name's Graham Jackson. I'm a GP. I'm Senior Clinical Advisor to NHS Confederation and the Chair of NHS Clinical Commissioners. I've got with me a panel of experts, but not a lot of time to talk to them. But I think that if anyone had any queries about the value of federations, we just need to send them that last 40 minutes of video feed to watch, and they'll really give a fantastic broad breadth of information there. Just quickly, on the tab on your screens, you'll see chat, questions and polls. If you go to the third tab poll, there's a couple of questions there we'd like to fill in. If you haven't done so far, please can you do that. So I'm going to ask each of my panelists as I go to them to introduce themselves. So it's just for time expediency. I've got a few questions to kick it off, and then we pick up some questions that you've been kindly putting into the chat for us over the last half an hour or so. So Tracy, coming to you first of all. Interesting discussion about epileptic recovery and involvement of secondary care from Julia and Chris. Could you just reflect as a system leader on that, the federations in that role, remembering just to introduce yourself as you speak, please?
Thanks, Graham. So first, to introduce myself, so I'm Tracy Bell. I'm a GP and Executive Lead for Primary Care and the Greater Manchester Health and Social Care Partnership. So I think it's really interesting what we've just seen, an interesting display of what we need to do in terms of primary care. In systems going forward, the most important bit is provider collaboration, and that's going to be key. That's not just key across secondary care horizontally, or actually across primary care horizontally, but vertically, as primary and secondary care seek to remove silos and handoffs and actually deliver a seamless care to patients. So in order to do this, we've been looking at our system in GM and the spatial levels that we collaborate at in primary care, first of all. So I think at neighbourhood level, we collaborate in the primary care network. And then at locality level, we collaborate at the federation level. But all these are put together into our GP provider board, which is almost like a GM federation. So our GP provider board is the voice into the ICS for the whole of primary care. And we've been operating like that for the last 6 years. What that can do is surface some of the problems at the front line and actually demonstrate how we could deliver better care in a collaborative manner with our colleagues in secondary care. So directly to the question, Graham, because I know we'll come on to other parts of this unique way of working. Our federations are really useful to reduce variation where it occurs in the system, but also to operate in terms of an intermediate tier, largely in the elective work. So we can be an employment host for many of our additional role staff, which are vital in terms of the pathways in elective recovery. So for an example, in endoscopy, we worked within that system to make sure that the pathway looks at the referral right through to the actual intervention. And that's where federations step in as the locality host for those contracts, but also deeply work with our practices, PCNs, as collective organisations. It's really important to understand that primary care has a history of collaboration, first in out-of-hours co-ops, but now in these two forms of collaborative work. Neither rule out or compete against each other, but all have their space in a new ICS going forward.
Lovely, thank you. Nice system view there. That's great. Kieran, coming to you next. I noticed on the platform it says you're Officer CCG. Of course, you will introduce yourself with a different title in a minute, and getting introduce yourself as you come online. But my simple question to you is: does the evolution of PCNs threaten the viability of established federations? Kieran, you there?
Hi, I am there. Sorry, just taking a few minutes. Sorry, that was a different question to the one that you had said you were going to post.
Oh, no, sorry, I did ask the wrong question, didn't I? I do apologise for that. I do apologise. That's my fault entirely. That's the question I want to put to Joe. Joe coming in first. My big mess there. Joe, you introduce yourself.
Thank you. I think you're doing a great job of chairing. Is quite difficult, isn't it, in this environment? Hi, I'm Jo Bailey. I'm a GP in Gloucester City, and I also head up GDOC, which is our sort of the equivalent of a federation locally. So I'd really follow on from what Tracy said. I think that PCNs and federations are offering something different to their patients and colleagues, and there is absolutely no reason for them to feel that they're in competition with each other. Federations were set up to support practices. PCNs are just a form of practices working together. There's no reason why they should be in competition with each other. I think the absolute core strength of PCNs is that they are very focused and knowledgeable about their local communities, but federations can bring in the wider sort of cross ICS view, and there's absolutely a need and a value for both. Organisationally, we've had some great examples in the recorded interviews about how well federations can support activities, particularly urgent care, that are quite difficult to do on a more fragmented practice or PCN level. Federations, of course, have the advantage of being legal entities, which most PCNs aren't, so that's very helpful from a recruitment point of view. I do think sometimes that, and there is as PCNs are evolving, there's a need to work out how you're going to work and what is best to be done at PCN versus federation level. And because these things are evolving rapidly, we are still learning about this. And I think, but on the whole, I think a flexible approach is the most successful one. So thinking of my own organisation, for example, we host some of the AR roles, but some PCNs choose to employ practices through a lead practice model. both work. There isn't a need for a kind of, an absolutely deterministic yes or no. We all need to work together flexibly to offer the system different things.
Thank you, Joe, and thank you for that complete. I just checking out all your adrenaline status there to get the question to the wrong person. So, Kieran, maybe now you can just relax and chill into the question I want to ask you, which is about your views on federations in place-based leadership, and also please introduce yourself with your appropriate title.
Thank you, Graham. Yeah, so I'm a GP as well, and for the last almost 4 years I've been a CCG chair, and then very recently I've just taken a role in the primary care team in NHS England. So yeah, so thank you for that. So the role of federations in place-based leadership, yes, is probably the short answer to that. So if I just sort of give a little bit of thoughts, a bit of background on where my thinking is with this, I mean, it's already been stated, but I see, practices are very much the building block of general practice. You've then got PCNs, which are very much around the local population and really looking at that sort of population health focus around a community. And then you've got federations, which are kind of at supra PCN level, so where they can offer support to practices, where they can offer capacity to deliver services beyond what a PCN might be able to do, and potentially offer some efficiencies, reduce duplication as well that otherwise practices or PCNs may have to do. So huge benefits to all of those three different layers. In terms of the leadership aspect, the beauty of general practice, as we all know, is that it's multifaceted, and you've got the LMC, you've got PCNs, and you've got federations, and each of those bring different skills and capabilities, and each of them have a very important leadership role to play within an ICS and ICP type setting. So the key thing here is how do we manage to galvanise those, bring them together, because they're all complementary. And as Joe just said, they're not in competition, they're very much complementary. And we know now more than ever before, perhaps, as we're moving into an ICS type setting and CCGs are fading away, that we need that really strong primary care voice. And that to me is not a single voice, because actually the beauty of general practice is it's not a single voice, but we do need to work out how we incorporate those different voices to have that really strong primary care voice. And that definitely, in my personal view, does include federations, because they're so important, have such an important role going forward.
Lovely, thank you, Kieran. I'm very cognizant of time here, but Anthony, coming in, having listened to what we've heard in the presentation so far, have you got some thoughts about the role of federations in the delivery of urgent emergency care in an area? Can you give some thoughts on that for me?
I think it was really interesting listening to Michael's stories from Bolton and Salford and the expertise that they've managed to bring together there. I think what we're hearing is that federations aren't something different from general practice, and that I think is what federations actually bring into a place-based response to the pressures in urgent and emergency care, and also the opportunity for innovation in urgent and emergency care. There's the opportunity for federations to support those practices who are perhaps struggling in their resilience or their access for their patients, and supporting alternative models where you improve the quality in those practices. There's something around federations being able to support general practices with consistent messages around how you can access general practice, particularly in the extended opening period, particularly the weekends when the public perceive that general practice is shut. Actually, here in Wakefield, we've got many of our practices do actually advertise themselves as available and open when their own general practice is open, but also up till 10 o'clock at night and on a Saturday and a Sunday when the GP Care Wakefield service, which we run through Connexus, is actually open. So there's something really, really important around communication. And then there is something very much we've heard around the agility that there is in federations to be able to corral and marshal the general practice resource at scale across a whole place to improve consistency, improve quality, make access easier, and also provide a kind of a single point where other parts of the urgent and emergency care system can come and talk to general practice about the pressures across a whole place-based infrastructure and actually come up with some innovative ideas, and then rely on the federation to support practices to be able to adapt and adopt. I think it's really important that we recognise that practices, the federations are nothing different from general practice operating at a different scale than on an individual general practice footprint.
Great, lovely. Thank you. I'm very aware of time, but actually it's being recorded, so we've run over a little bit for a couple of minutes. People can watch this later, so that's fine. I just really wanted to pose a question to each of you again from the chat bar, and really brief answers if you can. I think that there's loads and loads of conversations going on. Joe, coming to you first, there's a question from John in the chat bar about the evolution of the PCN DES beyond the 5 years. Now, we're about to embark on year 3 of the PCN DES, which many of us would have agreed was a bolt-on to the GMS contract. But actually, it's not sustainable on that, surely, in year 6. And what can federations do to support the future of the DES beyond year 5?
I think there are probably 2 aspects. One is just adapting to the speed of change and providing the infrastructure, and then there's actually providing some services on an ICS level that our practices and PCNs may find it easier to do through a federation basis. And we've already talked about urgent care, but there are many others as well. But I think it's sort of implied in your question, Graham, is the sheer speed of change to which PCNs have been reacting from 0 to now often having sort of multi-million budgets for employing AR staff and many other organisational requirements. And I think it's PCNs have responded amazingly to it and loved the challenge, but at the same time, it clearly causes operational challenges when they haven't previously been asked to work at that kind of organisational scale. So it's wrapping around those, providing the support, working very closely with them to understand their needs, and giving them the help that they need in a sort of non-threatening, as we've already discussed, and supportive manner.
Great, thanks, Joe. Let's come back to Kieran, to you. So you and I have both been CCG chairs in the past, and there's a question saying, do you think that feds could fill that void left by CCGs as local membership organisations for primary care? What's your view on that?
Yeah, that's a really interesting question. And I think as we move from CCGs to ICSs, one of the things that's happening in all systems at the moment is working out what the functions are of a CCG and where those functions go. And it may be that some are lifted and shifted into an ICS, but it may not be that that's an automatic thing. Every function just goes from one to the other. And I think we do need to, as we explore over the next few months, we do need to explore where those functions might go. Is that your alarm? Is that your clock, Graham?
Yeah, sorry, go about that. I'm just going to try and mute it. Ruth always says, "You never meet with me at midday." She always says, and so then what? Sorry, Kieran, gone.
That's all right. So I was just so working out which functions will be transferred where, essentially. And certainly at the moment, CCGs have a big part to play in supporting primary care. There are obviously parts which are around commissioning and contracting, but there are other parts as well around the development side of practices and the wider primary care. So potentially you could see how federations could fill that gap. So the developmental side of things, the supportive side of things that I think often CCGs have stepped in to do. So there are definitely, I think, some opportunities there. Yeah. Yeah,
great, thank you. I think we're hearing that, aren't we, at primary care speaking, that there's some support from CCGs, although there's some challenges against CCGs and support from CCGs for primary care that may well be lost. So 2 final brief questions from Anthony and then Tracy to finish off. So Anthony, reflecting back on what Catherine said in the interview with Ruth earlier on, about the HR responsibility, the ARS roles, the retention problems, and the challenges of PCNs doing that. And, federations surely are an obvious area to help with that HR responsibility. What's your view on that?
I think absolutely. I think it's really important that we don't create an infrastructure where we dictate what should happen with the management of those risks that you just outlined, but we actually enable and facilitate models that work in localities where there is a federation that has got the ability to be able to host the employment of staff, particularly the ARRS function staff on behalf of the PCN. I think some of the benefits include particularly from a practice perspective, actually offshoring the risk associated with some of that, and also the pressure. Practice managers are already very busy, and whilst there is funding for PCN infrastructure, it doesn't go particularly far. I'm not suggesting it's been under-generous, but particularly as the role and responsibility of PCNs extends and expands actually, one business manager and a small group of practice managers who are already desperately busy on a day-to-day basis, where's the resilience in the system then to actually be able to manage and support and oversee the work of the staff? I think there's also something very much for a federation around the opportunity to bring together the ARRS staff from across a number of PCNs to be able to collaborate and join together. There's something quite isolating about being an occupational therapist or a social prescriber in a single PCN, and actually, if they're hosted by the federation, there's some really good opportunities there to collaborate and cooperate and support and develop and train them. Retention is a really interesting question because it's not been going long enough in order to be able to understand what the impact on retention will actually be. We know recruitment can be fairly tricky and challenging, and retention is always difficult in NHS public sector organisations. So I think there's something really interesting to look forward to around how can federations actually provide infrastructure and support PCNs to retain those staff. And I think federations can do that. There's experience, there's expertise, there's resource in a federation often that can actually support retention and the importance of retention across those staff groups in ARRS role.
Thank you, Anthony. Okay, just to finish off, then, a brief comment from you, Tracy, on a very big subject. So I'm going to ask you about clinical leadership, because this plays into a session we're doing this afternoon, a conference at 3 o'clock this afternoon about the future of clinical leadership in the ICS. And I guess federations in their role in supporting that clinical leadership, and that's our representation of primary care within a system.
So I'll try and be brief, Graham, and it might be a little bit controversial. So we've been working as an integrated system for a while in Greater Manchester, and actually we find that we need to unite all our provider forms, all our general practice provider forms, and all the voice that they have. So we put together the PCNs, federations, LMCs together in a grouping, and then where that helps us, that can then lend to the system a clinical voice out of the provider voice. I do think both are different. A clinical voice is more about safety, around clinical priorities, whereas a provider voice is about delivering and how it can be delivered as a service. So I think you can extend out the clinical voice, but actually the provider voice is really strong. So where they all sit together, it allows for flow of funding or contracting to be decided amongst providers, whether it lends itself to a practice, to a PCN over a neighbourhood, or actually to a group of PCNs inside a federation, or actually do we deliver something at the scale of GM using one federation across GM. So it's a really interesting debate going forward. I think we need a strong collective provider voice to speak into the ICS first for primary care, and then we can decide how funding flows directly to providers in whatever form of collaboration is meaningful for providers on the ground, and actually co-produce with our citizens, because that's essential to get their view first, and that usually happens at practice or neighbourhood level, and then we bring that into the system and we can deliver at scale via our GP federations, but no competition, all in it together. We are united and stronger together in general practice.
Thank you very much indeed, Tracy. So to finish off, a thank you from me to my 4 panellists and all the contributors to the pre-record, which and this session I think hopefully will be played back around the country. Very difficult to summarise the session, but I'm going to give a very, very short summary, which is, if you haven't got a federation, go and get one. Thank you all very much for being here today.